Okay. Tilt this just a little bit. We'll just let it roll like that. Okay, so any questions what we're doing the next couple of weeks? Well, finish up positioning today, chest and abdomen, and then we'll back up and do chapter 1, chapter 2. After we get done with positioning today, and the only limited views that we're going to take of the abdomen just right now. So we'll do that, chest and abdomen today. Start back up with chapter 1, chapter 2. No class next Monday. We'll not pick up one of these days for lecture. So, any questions? So test chapter, the test over chest abdomen terms and all that are due on the 4th week. We'll have to see how that plays out. Okay, then to review chest positioning, PA and lateral chest, we shot a PA, we prefer to shoot chest x-rays PA wide. And what is PA? What does that imply? Posterior, anterior, it implies path to the x-ray beam. So path to the x-ray beam, anytime we say projection, we're talking about path to the x-ray beam. And so path to the x-ray beam is described by what the x-ray beam, let's say x-ray beam, what it hits first, followed by what it hits last. So PA implies it comes in the back, posterior surface, exits the anterior surface, so it's PA projection. AP would be the exact opposite of that. Anterior, posterior. Lateral is just lateral. And if we get to it today, we've got some other terms as well. Oblique is really a position. But it is still going to be a projection as well. So position and a projection. Position would be like anterior versus posterior oblique, what's closest to the image receptor, but it's still going to be AP or PA. But as we'll see later today, we've also got axial. And anytime you see axial, it's a projection, but it's a projection specific to central ray angulation. So you've got an angulation on central ray, is what axial is. But a PA, what are we looking for on PHS? Lungs, primarily, right? So we got lungs, but we also are going to be looking for other things as well, including the heart, the size of the heart. So the reason we want to put the anterior surface up close to the image receptor is because we reduce magnification of the heart. We also shoot the chest x-ray. Our two most common source to image receptor distances is from the x-ray tube and actually inside the x-ray tube on that spinny thing. That's where your source actually is, deep inside of the housing. So your SID, source to image receptor distance, is from that thing inside of the x-ray tube to the image receptor. So chest x-ray is 72 inches. That reduces magnification. Again, the video didn't work last Monday, so just to kind of give y'all this visual, if I put my hand really close to this board, the shadow, the outline of my hand is about this, the shadow of my hand is about the same size as my hand, and it's real sharp, right? But if I back it way up here, what happens? It gets real fuzzy, right? It gets real fuzzy and it gets real big. So we want to put our anatomy as close to the image receptor as possible, okay? But if we can't put it all the way up against the image receptor, and you can't put your heart all the way up against the image receptor, then what we can do to kind of overcome some of that is increase our SID. And I can use the analogy of walking under a street light at night. How does your shadow look? I mean, does your head really look all that big? Not all that big. Does it really look extremely fuzzy? Maybe a little bit, but not real bad, right? And y'all might, I don't have hair to make it look fuzzy. Y'all's might look a little fuzzier than mine does, but why is that? You're 5 to 6 feet off the ground. Your head is. Why does it not look fuzzy?
It's closer to the light.
Well, you're on the right track. The light, it doesn't. It might look a little bit fuzzy, but it's not this fuzzy, right? And why is that? Because the light is 40 feet up on the telephone pole. So your SID is quite high. You know, and think about, again, your shadow on a sunny day. Is there any fuzziness to your head on a shadow on a sunny day? Not really. Why is that? Where's the source? It's a long ways away, right? So the increase in SID overcomes that magnification to a degree. It reduces magnification and it reintroduces sharpness for recorded detail. All right, so PHS put the anterior side up against the image receptor as a preferred way to do it with the patient upright for a lot of different reasons. One of which is the patient can get a better breath. You can get 72 inches. It's going to be really difficult to get 72 inches with a patient laying on the table. So, you know, upright, get a better breath, visualize air fluid levels. You can get PA. So a lot of different reasons to shoot it upright. Preferred upright, preferred PA. You're going to position the top of the image receptor 1.5 inches above the outer portion of the relaxed shoulders. You're going to rotate the shoulders in. What was the purpose for rotating the shoulders?
Move the scapula.
Move the scapula. At the same time, whenever you do that, you know, my sternum is right here. Yeah, turn it up. My sternum is right here. You see the angle, right? Whenever I rotate in, what happens to it? It becomes very vertical. That's going to play a part here in a minute. We'll talk about AP, and we'll talk about you know, what we want to do with AP. So internally rotate the shoulders, get the scapula out of the way. At the same time, arms on the hips to rotate to get the soft tissue of the arms out of the way as well, right? So a lot of steps, but you're doing all these steps all at one time. You've got your patient, you say, I want you to go ahead and pat the board, put your hands on the patient. You know, I want you to put your chest right up against here. And, you know, while you're telling them what you're doing, you're feeling of them too. You're touching them and you're feeling of their back. Your patients, you'll find, will lie to your face. You ask them, little old ladies are the world's worst. They come in a nightgown, and the nightgown looks good, doesn't really have a lot of elastic, no buttons, no snaps or anything like that. No need to dress the patient. Take that off of the patient and put them in a gown, right? No reason for that, because there's no snaps, not a lot of elastic, no buttons, and everything's wonderful. Wrong. Your old lady's got a safety pin inside of her gown she's wearing from home, every single time. So you put them up again, but you know, it's best to go ahead and put them in a gown. But if you don't, you know, if you just decide not to, you're going to put your hands on the patient's back, and you're going to kind of feel for bra straps, feel for necklaces. While you're talking to the patient, I want you to put your chest up against this thing. And you get them up there, and you tell them, I want you to rotate your shoulders forward. And you just push their shoulders gently until they, you know, rotate as far as they're going to go. Because what's going to happen, you know, the patient doesn't really know what you want. And, you know, you tell the patient, I want you to rotate your shoulders forward. And sometimes, no lie, they'll do this number. Okay? You don't want them to do that. You just want them to push their shoulders forward. So hands on the hip, rotate shoulders forward, puts the sternum vertical, moves the scapula out of the way, keeps the soft tissue of the arm out of the way. So that's your PA. All right? So what's the difference between image receptor orientation? If you have patients of different body habitus, which body habitus are you always going to orient your image receptor if you've got an oblong image receptor like this? Which body habitus are you always going to put crosswise? Hyperstatic, right. And really, with me, I always put almost everybody crosswise, okay? And that's just up to you. Some people will put the image receptor lengthwise on almost everybody except for hyperstatic patients. I'll put it crosswise on almost everybody. Almost everybody will fit on an image receptor if you position properly. Top of the image receptor 1.5 inches above the outer portion of the shoulders. That puts a central ray where?
PA?
It's PA, but where does, at what level vertically does it go? Right to the bottom of the scapula, which is at the level of
T7.
T7. T7. So, top of the image receptor, 1.5 inches above the shoulders. You should be able to get pretty much everybody on the image receptor this way. The reason I go this way primarily is because, you know, if you have an asthenic patient, you probably, and you put your image receptor this way, you're probably gonna have to put the image receptor quite high and collimate, as opposed to here, your collimation is, you know, to the image receptor and then collimate laterally. All right, so that's your PA. And your lateral, which lateral do we shoot? Left or right, up against the image receptor? Left side up against the image receptor. Why is that? Magnification of the heart. Right, we want the left ventricle closest to the image receptor. Have the patient put their feet, or their weight equally distributed on their feet. Resist the urge to say, I want you to put your side up against there, because what happens in a lot of cases is the patient will do this, okay? And what that does is it takes your diaphragms, which should be projected, even though the right diaphragm is higher than the left, because of the magnification is further away from the image receptor, it should put them pretty much right on top of each other for your lateral chest X-ray. But if they're leaning, what's going to happen is the right diaphragm tilts down compared to the left diaphragm. Okay, so don't do that. Just have them put their feet, you know, their weight evenly distributed on their feet. Put their shoulder up against the image receptor. Have them elevate their arms to keep the soft tissue off of the image. So PHS should look like that. And how do we tell how can we tell if we've got a good PHS? What's our evaluation criteria?
Apices.
Apices. We want to see the apices, and we want to see the top of the lung above the apices, or the top of the lung is apices. The apices of the lung above the clavicles, right? We want to see the clavicles come in right around T4, right? And it gets a little bit difficult to count your vertebra, or your vertebra should correspond to your ribs. But your first two ribs are really stacked on top of each other, the posterior ribs. We can determine posterior versus anterior ribs, but the posterior ribs come all the way to the spine. They actually touch the spine. Anterior ribs don't touch the sternum. What you've got right out in here is costal cartilage that in turn connects to the sternum. So we've got first rib, second rib, third rib, fourth rib, and we've got clavicle. This is a clavicle, and it comes in right there. Okay, so it's good. Now, if you don't rotate the patient's shoulders in, those clavicles are going to appear too high. Okay, so again, you know, we took a look at the sternum. You rotate the shoulders in, the sternum becomes more vertical, but at the same time, what happens, you know, you walk around with your shoulders like that, and what do we call that? Slouching, bad posture, right? So your clavicles are here, and if you do the same thing, you kind of see what's going on with the clavicles, okay? So if you don't have the patient rotate your shoulders in, that's what your indication is going to be, is that your clavicles are going to be above the fourth rib. Okay, so if it's above the fourth rib, what's it getting into? What anatomy is that? The apex, right. So if the patient has some sort of disease process, a pathology in the apex of the lungs, you'll be able to see that very well? No. So important to rotate the shoulders. So that's one. What else do we want to see?
Costophrenic angles.
Costophrenic angles, right. It's at the little pointy things down there. Okay, so we got good costophrenic angles here. If you read through the book and listen to the lectures, you know, the posterior costophrenic angle is lower than the anterior or the lateral. So the lung is longer on the posterior side, and you'll see some lung markings back in here. And we're not really that worried about seeing that posterior costophrenic angle on the AP. You're just not going to see it very well anyway. Okay, so these are the ones we're interested in seeing. If you see lung markings, posterior side way down here, and you can see the costophrenic angles, you're okay. All right? So what else do we want to see? We want to see costophrenic angles. Any rotation? No. How we determine rotation is also by looking at the clavicles. See the way the clavicles appear to touch the spine? You know, you can follow the clavicle in, and this is the edge of the clavicle, and that's the spine. See the way it looks kind of like it's almost in contact with the spine? It's not, you know, because clavicles are here and spine's back there, but it kind of looks like it is. So if the patient's rotated, what's going to happen, let's say the patient is got clavicles here and here, right? Spine's right in the middle. So if I rotate this way, where's my spine going? That way, right? As opposed to my clavicles are going this way. So what's going to happen is this clavicle is going to be out in the middle of nowhere, and this clavicle is going to be over the spine. Okay? So if I go PA, it's kind of the same thing. Clavicles right here, right? So if I rotate, then this one's over the spine, this one's out in the middle of nowhere, right? So we want to look for rotation. We want to make sure we've got both sides of the lung. We want to see from top to the bottom, and that's pretty much our chest X-ray. PA chest X-ray. We also don't want to see any motion. And how you're going to hopefully eliminate motion is by having the patient do what?
Take a deep breath in, hold it, so let it out. Next
Blow it out, take another deep breath in and hold it, right? Don't forget to tell your patient to breathe afterwards. It's funny how literal they take things sometimes. They'll hold your breath just as long as they can. All right, so lateral chest X-ray, and y'all really kind of didn't. I don't remember whether or not I really pointed this out on the recordings, but let me run through why it is that we shoot two views 90 degrees from each other. If I can get to the. Okay, so you see the lobes of the lung. So this is a PA projection, or an anterior view, a frontal view. You see inferior, middle, and superior lobe of the left lung, or of the right lung, rather. Right? But look on the lateral. Where does the inferior lobe go? From all the way to the middle, or from the bottom, almost to the top. Right? So the inferior lobe is quite large, and on the left lung, it's the same way. It goes all the way from the bottom to almost all the way to the top. It's more posterior for a anterior versus posterior lobe more than anything else. So if the patient had a pathology, maybe they had a tumor situated right here, or better still, let's say it was situated right about here. Okay, where are we going to identify that? I mean, is it? Can off of one view could we identify exactly where it was if it was situated right there? No. We can't tell if it is in the middle of the inferior lobe or if it's in the upper portion of the middle lobe, the middle of the lower lobe, upper portion of the middle lobe, or lower portion of the superior lobe, right? But if we take that image, you know, it's way back here, and then maybe it shows up way back here on this particular image. We can, between the two, we can make a better diagnosis or a better guess as to where that would be. It would be in the lower lobe, right? Even though it's in the middle of the lung. So we take images 90 degrees from each other so that we can make diagnosis. Another example would be if we had a fracture. We had a fracture, a subtle fracture in this case. Looking at the shadow of this pin, does it look like there's anything funny going on? No. Just shadow of the pin? The cap looks like it's on there just about right? But if I turn it sideways, what do you see?
It's at an angle.
It's at an angle, right? So, in some cases, you know, like the pin's on there securely. Okay, so if I pull it apart a little bit, I can see that there's some sort of funny abnormality there, right? But I can't really tell what that abnormality is until I get, you know, two views. Can y'all see okay over here? Or was a straight in one? So with the pin in one projection, you can't really see much, but in the opposite projection, you can kind of see a little bit of a distortion Okay, so almost everything that we shoot, not everything, but most things that we shoot, we're gonna get at least 2 views, and if we can, we're gonna get them 90 degrees from each other. That's kind of a long review of PA and lateral chest, but do you have any questions on those? All right. Then oblique chest, we're not gonna hardly spend any time at all on. Oblique just means that we're not AP, we're not lateral, we're somewhere in between. There's a couple of different times that we're gonna do oblique chest x-ray. Most of the time that we do oblique, when it's not a standard protocol, is if the patient has some sort of anatomy or some sort of suspected pathology, some sort of suspected disease going on that you just can't get a good image of it. Like, for example, if somebody had a suspected tumor maybe close to the hilum of the lungs, which is where everything comes and goes, right? So you've got the bronchi, you've got maybe the right atrium, you got a lot of stuff that might be projecting a shadow over that pathology. They may ask you to do an oblique, and for the most part, it's 45-degree oblique. So with a 45-degree oblique, which a lot of our obliques are at 45 degrees, that's just halfway in between AP and lateral, or PA and lateral. AP and lateral, PA and lateral, 90 degrees from each other, right? So this is 90 degrees from this, so a 45-degree oblique will be halfway in between. Once in a while, a doctor will order what we call a cardiac series. The cardiac series utilizes a 45-degree left anterior oblique, left side, left anterior oblique would be here, okay? But it utilizes 60-degree LAO for cardiac series. So what that would be is a steeper oblique, is closer to lateral. That's not on the test, that's just in case you happen to run into that somewhere in clinicals, you know, the obliques and what, that is on the test, that obliques, you know, could be used to visualize pathology that PA and lateral won't show. Okay, but they just look like really ugly chest x-rays. That's what I was talking about before. You got spine here, you got one clavicle. Oh, we've got such a steep oblique that that clavicle is actually on the opposite side of the spine as opposed to the other clavicles just kind of out in no man's land. Okay, so AP chest, you will shoot almost as much as you will shoot PA chest. And that happens whenever we have a patient who can't stand up, and we either bring them to the department because they can't stand up, or it may be that they're so sick they can't come to the department, we have to go up to their room to shoot portable. So a lot of portable chest x-rays. Who got to do shadowing? A few of you get to see some portable chest x-rays and some AP chest, yeah. So if we can't do PA for whatever reason, the patient can't stand, or if we have to do a portable chest x-ray, then we're gonna try to accomplish everything on an AP chest that we did on a PA chest. So portable chest x-rays, you know, my entire career I shot one PA, the rest was AP. And the reason I shot that one PA was because I happened to come into the patient's room, he was sitting up on bedside. He really could come down to the department. He was eating his breakfast, and he just finished. I moved the table out of the way. I said, just hold on to this, and I shot him from the back. So one PA chest in my entire career that was portable. The rest of them were AP. So what we're gonna do is sit the patient up as much as you can, but there's a process, okay? So you walk into the patient's room, patient is kind of slouching on the bed because, you know, they're sick and they can't stand up. So what you're gonna do is lay the bed down first, and then you should have a draw sheet, and a draw sheet is just like a regular sheet, but it's folded over and over and over. So it just goes under their hips, okay? So you take the draw sheet, and you got somebody working with you. Usually there's two people, a lot of times there's two people on portable, and with you as a student, there's always gonna be two people on portable. So what you're gonna do is both of you get on either side of the draw sheet, lay the bed down, tell the patient to bend their knees and push while you pull them up in bed, okay? Now you can sit the bed back up straight and the patient, put their hips right in the bend of the bed. So that's number one. Number two is that if the patient is kind of, sitting at a bit of an angle, maybe you walk in and they're positioned far enough up in the bed that you don't need to pull them up in the bed, use the draw sheet in that case to straighten them out. Remember, these patients are really sick. So if you walk in, they're comfortable, they found a comfortable position, you tell them, I want you to straighten up in bed. What they're gonna do is they're gonna struggle and they're gonna push and they're gonna groan and they're gonna fall right back into the exact same position they were in before. So just tell them you're gonna straighten them up, whichever direction they are facing. I'm facing more to my left, get on their left-hand side, grab that draw sheet if it's under their hips, and just give it doesn't take a whole lot, just a little bit of a pull. And what'll happen is it'll pull their hips that way and the rest of them will straighten up. Okay, so use that draw sheet and straighten them up. And what you're gonna do is you're gonna put the image receptor behind the patient's back. So the top of the image receptor is gonna be where? Inch and a half above the outer portion of the shoulders, right? Excuse me. I worked outside a lot yesterday, all the dirt and stuff, so I got a long full. So, if the patient is, you sit them up and they got their hands bracing themselves up, where are the shoulders gonna be?
Too high.
They're gonna be high, right? So if you go 1.5 inches above that, where are you gonna put the top of the image receptor? Pretty much at their ears, right? So get their weight off of their arms, put their arms down to their side. Top of the image receptor, 1.5 inches above the shoulders, okay? Outer portion of the relaxed shoulders. Now, what you might want to do is before you get the patient all the way up, remember most of these patients are gonna be sick, most of these patients are gonna be older patients. So, all y'all are young. What you're gonna find the older you get is the stiffer you get. All right, so you get a 80-year-old patient sitting at an angle like that, and good luck getting the image receptor behind them. Okay, so because they're stiff, you start pulling the patient forward, and the hammies just can't tolerate it anymore. Right? So what you might want to do is get the patient part way up, put the image receptor behind them, and then sit them the rest of the way up. Okay. Top of the image receptor, 1.5 inches above the outer portion of the shoulders. Make sure that you've got the image receptor. I'm just going to put this in front of me because, what you want to make sure is you've got image receptor on both sides of the patient. It's very easy to put the image receptor too far in one direction or another. You want to see the same things. An AP chest is what you saw on PA chest. So you're going to clip a costophrenic angle or an entire side of the lung. So make sure you got image receptor on both sides of the patient. Tell them to pull their arms out so that you can see where the image receptor is. Now, your central ray is going to be collimated to the size of the image receptor. And it's going to go to T7, same place. You can't see the inferior border of the scapula in this case, so you're just going to have to go with the image receptor as your guide as to where to put the central ray. Now, what was the central ray perpendicular to on a PA when you rotated the patient's shoulders? What became vertical when you rotated the patient's shoulders? Sternum, right. The sternum became vertical, right? So what did I say was going to happen if you didn't rotate the shoulders forward on PA? Where were the clavicles going to be? Too high, right. So if you angle perpendicular to the central ray, or perpendicular to the image receptor, it's going to be as if you stood the patient up and didn't rotate the shoulders forward. So your central ray needs to be perpendicular to the sternum. Okay? And that's regardless of what the patient looks like. Sometimes you'll have a patient who's kyphotic, and kyphotic patients are, in a lot of cases, are patients who've had multiple compression fractures. You see some of these older patients who just, you know, they've got almost like a hunchback where they didn't really have a hunchback when they were younger. Okay, that's a natural progression, unfortunately. Is that sometimes you get compression fractures, sometimes your intervertebral disc spaces narrow and you get that appearance. I've had patients that were so kyphotic, and that's what that means, is it's kyphotic, they're bent forward. Lordotic is as if you're leaning backwards, kyphotic is as if you're hunched forward. Okay? And I've had patients who were so kyphotic I had to get at the foot of the bed and an angle up to be perpendicular to the sternum. I had a beautiful x-ray, but it needs, you know, regardless of what the patient's anatomy looks like, you need to be perpendicular to the sternum. Okay? The step that you're probably not going to see a lot of techs, you know, accomplish on a portable chest X-ray is placing the hands on the hips and the scapular lateral. Most of the time, you're just not going to see that. But you do need to get the arms out of the way, okay? Because again, these are older patients, you know, the older we get, the looser the skin gets, and it can show up an artifact. An artifact is something on the image that you don't really want to see. Something out of place, like buttons would be artifact. This would be a soft tissue artifact on the lateral portion of the thoracic cavity over the lungs. So make sure that you get the arms out of the way, even if you don't, you know, rotate the shoulders forward. All right. So that's a little bit lordotic. The clavicles are a little bit high, but you know, depending on really, I would be hard pressed to reshoot this without a radiologist pitching a fit about it, and I think a radiologist would be hard pressed to pitch a fit about this X-ray. So what we've got is we've got from the apex of the lungs to the costophrenic angles. Clavicles are a little bit high, so the amount of angle perpendicular to the image receptor instead of perpendicular to the sternum. But what you've got is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 posterior ribs. Remember, posterior ribs come all the way to the spine. So it's really a good X-ray, good chest X-ray, or portable chest X-ray. So once in a while we'll have an X-ray where, or a patient where they've got some pathology, maybe TB, in the apex of the lungs. So we need to see the apex of the lungs with as little superimposition as possible. So superimposition is just where we've got one thing stacked on top of another thing, okay? So we've got superimposition, you know, how many shadows of the hand do you see there? 1, yeah, so, but, you know, we've really got 2. So superimposition just means one thing stacked on top of another. Remember, we're looking at a 2-dimensional image, length and width, of a 3-dimensional structure. So things are going to be stacked on top of each other. That's why the clavicles look like they hit the spine when they don't, is because it's 2-dimensional perspective. All right? So if we have something in the apex of the lungs that we want to see, maybe a TB or a tumor or whatever, then we can shoot a lordotic chest X-ray. And there's a couple of different ways that we can do this. There's a number of different ways. I'll tell you what the book says, and then I'm going to tell you what you really should be doing. Most of the time, these patients are really, really sick. This says AP, apical lordotic. So AP would be AP projection, right? AP is always projection, AP projection. But it's AP axial, and axial means angle on the central ray. Okay, either angle on the anatomy, angle on the central ray. And what the textbook says that you need to do is get the patient upright, have them step about a foot away from the wall bucky, the image receptor, and then lean back into it. Does that sound like a good idea to you? For somebody who's sick, maybe has TB, probably older, does that really sound like a good idea? No, it does not. So, just know that you know, the positioning steps call for having the patient step out about a foot and then do limbo back into the image receptor. If you're going to do that, what you need to do is you need to find a chair for the patient to sit in. A low back chair, not a stool, especially not a rolling stool, but a low back chair where the patient can sit down and scoot their hips out and then lean back into it, okay? That's the only time you should be doing that. Is you do this, and you may very well be doing a skull series on the patient too, because they're going to the floor, okay? Don't ever do that. But what we're gonna do is we're gonna put the top of the image receptor 3 inches above the shoulder. Remember, in this case, we're looking at the apex of the lungs. We're not looking, you know, for the entire lungs. Central ray is gonna be perpendicular to the image receptor. It enters just below the jugular notch, which is that soft tissue indentation right there. And you poke on your sternum, and you keep going up until you go, okay, that's your jugular notch right there. So your central ray is just gonna be right below that, and you're gonna make your exposure at the end of the second full inspiration. So how you're gonna do this without leaning the patient backwards is by truly doing an axial. So you have the patient stand up, or if the patient's on the table, they're just laying flat on their back, and instead of angling to the sternum, what you're gonna do is you're gonna angle cephalad. And the amount of angulation is gonna depend on how thick the patient is. All right, so you got a patient who's got a big barrel chest, big thick barrel chest. It's going to require less of an angulation. So if I've got somebody who's real thin, you know, the chest is real narrow, it's going to take more angulation to separate those two than if you've got somebody who's got, you know, a great big thick chest. Okay, so your angulation is going to depend on not really even the patient's body habitus, but rather the patient's body build. If they've got a big, thick barrel chest, then you're going to need less of an angulation than if the patient's got, you know, a very thin chest. So what we're going to do is we're going to be looking just at the apex of the lungs. So we want to look for collimation in this case. You don't want to use a 14 by 17 or a full-size image receptor to image the apex of the lungs. Even though you're looking for chest X-ray, you're only looking for this much of the lungs. Okay, so only use that much of the image receptor in the beam. But we're still going to be looking for rotation. We want to see the entire apex. The clavicle should be over the upper portion of the apex of the lung, so we see most of the apex of the lung without superimposition. You're not going to see the entire apex. You can see most of it. We still want to look for rotation. We don't want rotation to be present. We still want to see the clavicles, visualize the clavicles. They should look very horizontal, means, you know, flat, right? And the ribs just look ugly. So it looks like that. Bad patient care, bad radiation exposure. That entire image should be about that big, okay? All of that should be gone. So your collimation should just be to the apex of the lungs. No reason to use an entire 14 by 17 right forward on it. Okay? Any questions? Okay, so we got the cubitus. In radiology, the cubitus means two things. One is that we've got the patient laying down, and just by anatomical terms, the cubitus just means laying down, but in X-ray it means two things. One is it's laying down, and two is that we've got a horizontal central ray. Okay, so let's make believe this is a clear cup. All right, so it's clear, it's a measuring cup. So you're making something, and you need a precise measurement, right? So it's a clear measuring cup, and it's got lines on it. So how do you visualize that you've got just the right amount of water in the measuring cup? You look down on it like this?
Look from the side.
No, you look at it like that. You get on eye level with it, okay? So decubitus, every time we shoot a decubitus, that's what we're trying to visualize is their fluid levels. So on chest X-ray, we usually get that with patient upright. But what if the patient can't stand? Well, maybe we can do an upright chest x-ray with the patient, on the bed, right? But what if the patient can't sit up? Well, then we have to do a decubitus. A decubitus, we're going to shoot for one of two different reasons. One is that fluid level. Maybe the patient has a pleural effusion. Now, pleural effusion is where we have fluid that's inside the thoracic cavity but outside of the lungs. If it's inside the lungs, it really doesn't move a lot much. That's a pneumonia. But a pleural effusion is fluid inside the pleural cavity, and it can go anywhere. Okay, it can go anywhere inside the pleural cavity. And what happens with pleural effusion is that if it gets big enough, it starts to compress the lung. A very small pleural effusion, it's a problem, but it's not as bad as if somebody has a 40% collapse of the lung accompanying pleural effusion. So it displaces the air, and the patient has less lung volume. So how we would visualize a pleural effusion is with a decubitus. And what we would do is take the patient, lay them on their side, and that fluid would, because it's heavier than air, it would go down towards the floor, right? Because of gravity. So if a patient has pleural effusion in the left lung, I'll lay them on the left-hand side. Where's the fluid going to go? Yeah, left side, lateral side, right? So if I have fluid in the right pleural space, and I lay the patient on the right-hand side, it goes all the way off to the right-hand side. But if I have fluid in, let's say, the right pleural space and I have pleural effusion on the right-hand side, and I lay the patient on the left-hand side, where's it going to go?
To the left-hand side?
Well, the two, you would kind of think so. It will go to the left-hand side of the right pleural. The two pleura don't communicate with each other. So it's never going to go to the left-hand side. It's just going to go to the right-hand side, or the left-hand side of the right pleural. Does that make sense?
So more medial.
So it's going to be more medial, which, what do we have more medial? The media sternum. We have sternum, we have mediastinum, we have spine, we have heart, we have great vessels. How could you tell the difference between pleural effusion and all that other liquid-filled stuff? It's a trick question. You can not. Right. So if we're interested in fluid on a decubitus chest x-ray, what side do we put down? Do we put the patient in a position where the fluid goes into the mediastinum or laterally? Laterally. Every single time we're looking for fluid on a pleural effusion or on a decubitus chest x-ray, we're interested in putting the side of interest closest to the tabletop, right? So we got left pleural effusion, we're going to put the patient on the left-hand side. All that fluid's going to go down, right? And then what we're going to do is we're going to put the image receptor either in front of the patient, so I'm laying on my side. We're going to put the image receptor either in front of the patient, shoot PA, or put it behind the patient and shoot AP. Okay? It doesn't really matter if you shoot AP or PA. In my experience, it's better to shoot AP than what it is PA. And the reason for that is because, again, most of the time these patients are really sick. Most of the time they're very old, less flexible. All right? So if you have somebody who just doesn't have the flexibility in the shoulders, and you put this up against their chest and you tell them to raise their arms because you got to get them out of the way, and they can only go that far, are you going to see the apex of the lungs? No. Not unless you put the image receptor like this, and that's just going to make an ugly x-ray. Okay? Is that a problem with the image receptor behind them? No. Is it a problem that we're going to have magnification of the heart? In this case, really no, because what are we looking for? Are we looking for the heart? No, we're looking for a pleural effusion, right? So magnification of the heart really doesn't play a part here. I recommend you shoot them AP. You run into fewer complications with AP as opposed to PA. You shoot them either way, but your practical hint here is shoot them AP if you can. All right, so everything else applies to the decubitus as it did for the normal AP and PA chest. Central ray should be the T7. What you want to make sure that you get is this side closest to the image receptor. Now here's the hard part about this, is this. We've got, let's say, all right, so we want to put the central ray perpendicular to the image receptor, right? For reasons we'll talk about throughout the semester. But the central ray comes from a point source. It comes from a little bitty point source, kind of like a light bulb. I mean, all that light comes from a little bitty, spot up in there, right? So it's got to spread out. So watch what happens, if I can make this happen. Watch what happens to the appearance of this thing if I have it pretty much going parallel to the light source. You see how small it gets? Now if I can walk over this way, look what happens to the shadow of it. You see the way it distorts? Okay? I tried not to move this much, but can you see? Okay. All right, so on a decubitus chest x-ray, if the bottom of the patient is right here at the bottom of the image receptor, and my central ray is pointing a little bit down like that, what's going to happen to the anatomy? Is it going to be on the image receptor? It's going to hit the anatomy right here, and it's going to project it off of the image receptor, right? So how could you avoid that from happening? Two ways. One is drop the image receptor down, but if it's already on tabletop, can you do that? No, so what might you have to do? Elevate the patient up, right? So the patient, what you may have to do in order to not miss the pleural effusion is take some sheets, some blankets, and put it under the patient to elevate the patient so that you can see the pleural effusion. So you might be thinking, what if I elevate the patient too far and I miss the top side lung? Is that a problem if you're looking for a pleural effusion? Not really. I mean, radiologists might grumble about it, but what anatomy are you looking for specific for this case that we're talking about? Top lung or bottom lung? Bottom lung. So are you going to miss the anatomy of interest if you miss that much of the top lung? No. You make sure you get that bottom lung, right? If you got to build the patient up. Now, let's flip all this around and say the patient's condition is not a pleural effusion, it's a pneumothorax. Now, same pleural space, you've not got a collection of air or fluid, you got a collection of air. Patient broke a rib and they collapsed the lung. They broke a rib, and in breaking a rib, they punctured that pleural space, and that pleural space, it should have a negative pressure so that it helps you to breathe. You lose that negative pressure and it sucks some air in. Okay? Now, let's say that's a pneumothorax. We lay the patient on the left-hand side for pneumothorax. Where's that air going to go? Is it going to go down? No. It's going to go towards the towards the right side, right? So what do you have in the mediastinum that's full of air too? You've got, the bronchi come down and split, and then you've got, in addition to that, you've got the sternum, you got the spine, you got all those fluid-filled structures that are tough to penetrate and tough to, separate, and then you put something like air on top of it. It's going to make it very difficult to see the air. Okay. Plus, you got this, the trachea, the bifurcation. It's just going to make it tough. So, if you're interested in a left side pneumothorax, what side would you prefer to put the patient on? Right side. Right? Because the air is going to go up. So, decubitus, two different possible conditions for decubitus: pleural effusion, side down. Pneumothorax with the side up. Now, it's pneumothorax. If you're interested in pneumothorax, which lung do you want to make sure that you don't accidentally collimate off or project off the image receptor? The side up or the side down? Side up, right. So pleural effusion, make sure you get the side down. Pneumothorax, make sure you get the side up. Everything else is just like a PA or AP chest x-ray, central ray to the the T7 and all that. So that's what it looks like, and that is truly a pretty nasty pleural effusion. See, the edge of the ribs are down here, and all of that is displaced fluid. And so you can even see the separation of the lungs there, the separation of the lobes of the lung. Okay, so that's what pleural effusion looks like. All right, any questions? We'll pull up there, take a break, and we'll be back, say 5 after, or 35 after. Take a little break, and then we'll talk about, run through ventral dorsal decubitus just real quick, and then we'll talk about abdomen.
Will these slideshows be available for us, or?
No, those are your slides there, but you can